All right, I think we'll go ahead and get started. Um, Hi, everyone. My name is Laura Callan. I'm with Digital Square at PATH. Thanks so much for joining us today. We're excited to be able to talk about digital public infrastructure for health. Before we get started, just a few housekeeping items. Of course, please keep yourself muted during the presentations, and then at the end, we'll have time for a Q&A session. When we get to that point to ask a question, please either use the hand raise function, which you can find under reactions, and then you can ask your question out loud, or alternatively, you can type your question in the chat. We'll get it either way. We will also be recording this webinar to post on our YouTube channel. Just wanted to let everyone know. So with that, I will hand it over to Tim Wood from CoDevelop for an introduction.
Hi, everyone. Thanks for joining us today. I'm Tim Wood with CoDevelop, and CoDevelop, for those of you who are not familiar, is an organization that is focused on accelerating country adoption of digital public infrastructure. And a little while back, we decided that we wanted to take a look at how digital public infrastructure could be applied to the health domain. And so with support from the McGovern Foundation and the Wellcome Trust, we asked Vital Wave and Digital Square to do a deep dive into the existing state of the digital health ecosystem and the technologies that were available there, with an eye towards applying what we've been calling infrastructure thinking to the digital health domain. And this report is something that we are very excited about. We think the team has done fantastic work and are hoping that will bring a new type of thinking and approach to digital health and will accelerate the adoption of impactful digital health systems for developing countries. So with that, I'm going to hand it over to the Vital Wave and Digital Square team. And I think, Amy, you're taking it from here.
Yep. Thanks so much, Tim. And thanks, everyone, for joining us today. Go ahead and do next slide. Great. So during our time today, we're going to take you through the journey that we have been on in putting this work together. We're going to start with a little bit of conceptual thinking around how we started thinking about what digital public infrastructure in the health domain might mean. As you'll see here, we started without a very precise definition and kind of worked through it as we were exploring the space. So we'll take you through our thinking there. We'll go through a series of user journeys that we use to identify what the components of digital public infrastructure for health might be. Again, trying to take this inductive approach of focusing on priority use cases and unpacking what those common enablers might be across them. From that point, we'll get a little more practical, acknowledging that digital public infrastructure for health is often implemented through applications. And so we'll take a look at the existing digital health product landscape. We'll look a little bit at the broader enabling environment, and then we'll close out with some recommendations before having some time for Q&A. So you can go ahead and go to the next slide. So again, here, just a little introduction to digital public infrastructure and digital public infrastructure for health. Next slide. In case you're not familiar, we just wanted to put a little bit of background here of the foundational digital public infrastructure thinking. There's a lot of definitions out there. It's an evolving concept, but there does seem to be some emerging consensus around what it means to take a DPI approach or infrastructure thinking. We put a few definitions up here. One from CoDevelop, from Digital Public Goods Alliance, but you'll see there's some common features here in thinking about looking at components that are going to enable digital capabilities that are essential to participation, that they're inclusive, generally characterized by a set of technologies that are interoperable, that are implemented under a governance model, and that support a broader ecosystem of applications. You'll probably see common examples as digital identification systems, digital payment systems, or data exchange. So these are kind of what you'll see in the broad DPI approach. What we're going to do with this work is go beyond these and look specifically at what it might mean to take this approach into the health domain. thinking about what are the core capabilities that enable participation in the health system, what are the core capabilities that are going to enable the use cases that we want to see now and in the future, and then looking at the technical components that underlie them. So if you go to the next slide, you can see a conceptual model for how we put this together. We built off a conceptual model that Guile had used that starts to relate some of these concepts of technology infrastructure, foundational digital public infrastructure, and domain-specific infrastructure. And so for this work, we're really focusing on this blue layer in the middle, looking at the digital public infrastructure that might be specific to one particular domain, but is in addition to the foundational DPI that a country might have in place. So again, it's not necessarily in place of, but we're really thinking about what are the components that are specific for the health sector and the health system outcomes that we want to achieve. If you go to the next slide, we're just zooming in here on, again, digital public infrastructure for health and the kinds of digital applications that are implemented on top of it. I'll just pause. We're getting a little background noise just to remind folks to stay on mute if you can. Okay, go ahead, next slide. So to unpack what really is sitting here in this digital public infrastructure for health approach, we can go ahead to the next slide. We're identifying a set of use cases that we could look at as what are kind of the kinds of capabilities and priority use cases we would want a digital health system to have. And we did this by putting together a series of user journeys that represent a set of priority use cases that we think health systems might want in the next 5 to 10 years. So we use this approach, again, to identify a broad set of those functional digital applications you saw at the top of the model and try to unpack them into the digital components that are common horizontals across them, to look at those common components as what digital public infrastructure in health might be. Next slide. We put together 3 user journeys. You're seeing them here, one focused at the client level, one at the healthcare worker level, and one at the health system manager level. And the idea here was to be able to look at digital health interventions and use cases that were important across multiple levels of a health system, right? Of course, those that are important for client care, those that were responding to kind of the needs of healthcare workers and health service delivery, and also thinking at some of the broader public health functions that rely on aggregate data and system level capability. So what you're seeing here are a set of use cases that we identified under each. And the goal here, again, was to find use cases that had broad relevance. We had many conversations with digital health experts. I'm sure some of you are joining here today. But really to look at what are some of the core use cases and interventions that we would want. Just to highlight a few of those, there's some around at the client level, care service discovery and thinking about the continuity of care across providers, across systems, thinking about secure access to medication and how to find and locate care. We also included a couple of more forward-looking interventions, including those that would leverage emerging capabilities like machine learning and AI, thinking about precision public health targeting and segmenting care to different parts of a population based on vulnerability or need, as well as some that kind of combine that underlying DPI by looking at digital payments and vouchers within the health system. At the healthcare worker level, some of the use cases that came up to the top were around streamlining data capture and messaging, really thinking about ways to make more efficient use of the limited time that healthcare workers have, kind of acknowledging the shortage of healthcare workers many countries are experiencing, and wanting to find ways, again, to make that more efficient, whether that's reducing kind of redundant data capture, making options for remote consultation available, thinking about, again, predictive analytics that are going to help with risk-based scoring and prioritizing care based on need, as well as a lot of the training and supportive supervision kinds of activities. And at the health system level, again, these were kind of focused on more public health needs, outbreak analytics, communication between health managers and health workers, and again, building in that forward-looking predictive analytics for outbreak forecasting. So the idea here was not to come up with a comprehensive list of all use cases, but to really get a broad selection that were going to help us identify patterns in the kinds of digital components that you would need to implement these kinds of interventions, and to look for patterns across those to come up with common underlying components. If you go to the next slide, again, this is not something that you need to read in detail, but it's meant to really give you a sense of just the process we went through in unpacking these different use cases and segmenting out the different kinds of digital components that are important for it. We did this kind of keeping in mind that conceptual model that we talked about at the beginning. So some of the basic underlying technology infrastructure components are in the gray. Those we kind of segmented into what would be included in foundational digital public infrastructure. Some of the very specific kind of applications that would put these in use were sorted into the top in the teal bar, where you have those functional applications as part of the ecosystem. And what we had in the middle, where you see a kind of a denser collection of those check marks, are what stood out as those common underlying features for digital public infrastructure for health. If you go to the next slide, we'll unpack those a little bit more. What you're seeing here, again, I'm going to take you through in a couple of different layers. And just to remind you, this is kind of a deep dive on that digital public infrastructure for health domain that we saw in the main model. I'm going to focus first here on the blue layer in the middle. And this is really, again, that core components of digital public health infrastructure. We came out with 5 basic categories. You'll see the registries and terminologies services on the left, health domain interoperability, scaled health services, central health data repositories, and health data security frameworks, kind of cross-cutting across the bottom. You'll notice that, this overlaps very much with the Open HIE framework, and I think that's to be expected, right? These are common components that really facilitate a health information exchange. There were 2 components here that are not entirely overlapping with that. One is the central data repositories. That kind of came out of looking at those forward-looking predictive analytics use cases where it's very useful to have a repository separate from your operational databases that allows you to do analytics. And then, of course, the health data security frameworks across the bottom that really stood out given the number of use cases that required sharing patient data across systems. The second thing I'll point out that came out of this analysis is in the teal layer up at the top. So in order to enable many of the use cases that we saw in the user journey, there were a need not just for these underlying infrastructure components, but sometimes open data or training data to train a machine learning model or an open model itself. And these were things that were not an application in itself, but were also not as common as the core underlying infrastructure components. And so we categorize these as supporting digital public goods, right? These are the kinds of inputs that are going to be important for building applications on top of DPI, but in and of themselves, were not part of that core infrastructure, but really just contribute to that broader ecosystem and the kinds of applications that can be developed with them. The last part I'll highlight is in the kind of yellow color on the bottom, and this is a services gateway. What this is really just a note to the connection to that underlying foundational public infrastructure. So again, some of the use cases that we looked at had a payments component. And the idea here is that you're not recreating that in each sector, but that you have a way to leverage that underlying foundational DPI where it's in place. So that's kind of the technical part. If you go to the next slide. The last piece of this conceptual model is really looking at the broader enablers in the ecosystem. So much of this is not possible to implement as an infrastructure approach unless you have kind of strong leadership and governance. That governance piece is really a core part of putting the public and DPI and thinking about making sure that this is inclusive and implemented with a strong governance model. And that's not different when you look in the health domain. So again, we've noted here the importance of leadership and governance capacity to set a strategy to take this kind of infrastructural approach. That might include things like digital health strategies, health enterprise architectures, key governance assets that are important for implementing this. The data governance piece again came out just looking at how often health data is moving around through the different systems in these use cases. And certainly the technical workforce capacity, right? To have human resources to be able to use and maintain and develop these core components of digital public infrastructure for health. So that's kind of the conceptual thinking that we did to figure out what are we talking about when we say digital public infrastructure for health. What are the components that we need to look at? From here, we're going to look at some of the applications and products that would help to put this into practice. And so for that, I'm going to turn it over to Pierre.
Great. Hi, everybody. You can move on to the next slide, please. So the next piece of the work was looking at the existing ecosystem of digital public goods. So we looked at a superset of the products that are listed in the Digital Public Goods Alliance DPG list, the Digital Square Global Goods, and products and building blocks and dials, Digital Impact Exchange. We could move to the next slide, please. So here you see a chart just showing the different categories that Amy outlined previously. You can see there's a number of different products in the different categories. Just to note that obviously some of the products fulfill more than one function, so they exist in more than one of these categories. So the first one is scaled health services, and this is analogous to the business domain services in OpenHIE. They're services with open APIs, central operational data stores, and they can interoperate with points of service systems in a standards-based manner. We'll go into a bit more detail about the different types in a subsequent slide. The next category is the registries, which are also very familiar to the OpenHIE folks. We'll dig a bit deeper into those as well. The third category is health domain interoperability. This is also part of OpenHIE, of course. So it's the interoperability layers like OpenHIM and OpenFunction. It's the standards themselves, including FHIR and all of the terminologies, but it's also the building blocks and the software development kits that enables the use of these standards, especially standards like FHIR. It includes Google's Open Health Stack, Android FHIR SDK, and other FHIR ecosystem components, clinical query language, FHIR IGs, implementation guides, and the smart guidelines. So the next two categories are the ones that Amy was mentioning are not explicitly mentioned in the OpenHIE architecture. So health data repositories include national data warehouses and other data repositories that contain aggregate and client-level data, which can be used for research, for monitoring, evaluation, and to build and train the models, the machine learning and AI applications that Amy mentioned. So something like DHIS2 is included here as an HMIS. There's others included like DPI, Harmony, Lasso, but a lot of countries use non-health specific technology, just vanilla Microsoft SQL Server with Power BI, etc. The last category is health data security frameworks. So this is an underrepresented category. There isn't a lot of work being done on this, especially around consent. So clients being able to control which pieces of their health data are shared with different data consumers. There is some work done around informed consent for specific research studies, but it's not really operationalized as part of a health information exchange. There is a lot of work going on as part of India's national health stack. So part of that, there's a fiduciary framework and a consent mechanism. That's a very core part of that work. So that's ongoing. If you could go on to the next slide, please. So here we're drilling down into the scaled health services. You can see no real surprises here. These are all the services that we're familiar with from OpenHIE, lab information systems, services, logistics, disease response and surveillance, etc. But notably, there's a gap in the shared health record service over there on the left. So we're expecting fire service to start really filling this gap, but the scaled use of fire service in the LMIC contexts is limited. Shared health records or shared health record services are a key dependency for the development of assets like international patient summaries, longitudinal patient records, and personal health records, which are things that were highlighted as very critical by many of the people that we spoke with. Next slide, please. So these are the registries, client registries, facility registries, health worker registries, product catalogs, and terminology services. So there's a number of these tools of different levels of shelf readiness, and I'll speak a little bit more to shelf readiness in a subsequent slide, and different levels of implementation and maturity at a country level. So some of them are implemented at nationally at scale, but there is sometimes limited interoperability and use, maybe less than we'd expect. Next slide, please. So this slide talks to the supporting DPGs that Amy mentioned. This is open data, open content, and open models, so AI and machine learning models. There are a lot fewer of these in the DPG space, especially in the health sector. They're harder to find, and they're less uniform in the use of standards. The licensing models are unclear, and there's a lack of documentation on how the data was collected and how it can be used. So it limits their use in a digital public infrastructure for health ecosystem. As there's increasing interest in AI-enabled use cases, the demand for these kinds of assets will increase. So it's something that we need to focus on. Next slide, please. So in terms of just summarizing, there's many existing DPGs that can be combined to build infrastructure and functional health information exchanges. There are some gaps, especially around the consent frameworks and the shared health record services, and then the supporting DPGs, the content, data, and open models. There's also varying levels of shelf readiness of the existing product sets. So we're using the digital square definition of shelf readiness, which includes measures of security, ability to operate at scale, population scale, implementation of standards and interoperability, documentation, and quality assurance. So while we recognize that country contexts and workflows in country are very different, and there's definitely going to be need to configure these products for country contexts, so they're not necessarily going to be completely off the shelf. But if there is a high level of shelf readiness and less technical debt, and they're easy to deploy, it lowers the bar for implementation of these as digital public health. Digital public infrastructure for health. Next slide, please. So I'm just going to look at a few groups of challenges in the implementation of digital public infrastructure for health in our contexts. Next slide, please. So starting off with country enabling environment challenges. There has been exceptional progress over the last decade. Several countries have developed blueprints, digital health strategies, and enterprise architectures. Now those strategies are starting to be implemented. The next step is to realize them as infrastructure. However, there's still a key challenge in country workforce capacity. At a leadership level, there's a lot of very committed leaders, but they have multiple priorities. They're often overburdened, and there's sometimes high turnover of people in those positions, and a lot of redeployments of staff. There's also a short the expertise in digital health architecture is in short supply. Coupled with that, there's limited capacity to set and enforce regulations. So the regulatory organs are sometimes there, often there. The regulations are there, but the ability to actually enforce those regulations is sometimes not in place, especially around protection of personal information. Next slide, please. The next piece is around technical debt and private sector regulation. So this is talking about the maturity of the available digital public goods and how ministries of health engage with these products and with the private health sector. So digital health technology, the terminologies and the standards are complex, and the cost of configuring, developing, and maintaining open source products is underrepresented generally in the total cost of ownership of these products and the operational expenditure necessary to maintain the use of them. So this needs to be considered in the context of products available in the private sector, looking at the licensing implications and the shelf readiness of those products, and comparing total cost of ownership. There is a shortage of software developers and technical staff well versed in digital health to work on these open source code bases, and there's a lot of competition from the private sector for these same staff. Ministries of health also have a very legitimate fear of vendor lock-in when using proprietary products, and again, there's a lack of clarity in total cost of ownership, the difference in the total cost of ownership between these open source tools and proprietary products. So countries need to be able to choose and have guidance on which kinds of products to use. Do they use open source DPGs that may not be as fully mature as some of these proprietary products, but then there's also other considerations like the financial side and the data ownership challenges. Next slide, please. Okay, this last slide is to do with the way that digital health systems have historically been implemented. Historically, digital health systems have consistently focused on data capture for programmatic M&E, rather than prioritizing data for use at service delivery level and for client care. And this has resulted in disease siloed and non-interoperable systems. This fragmentation has also resulted in a plethora of different digital tools and paper systems being used at the same time by the same health workers across different programs, which adds huge workload and a lot of complexity to the health system. And in addition, the aggregate data that's captured for monitoring and evaluation and program management, and the patient data collected without appropriate consent has limited usefulness for client care and for research and for the development of machine learning and AI models. And I'll hand back to Amy to discuss some of the approaches to mitigating these challenges.
Great. Thanks, Pierre. You can go ahead and go to the next slide. And next slide. So following all of this, this is a multi-part slide, and I'm going to walk us through it here. But what we did is kind of take what we learned about kind of DPI for health thinking, what we understand about both the state of the products and the enabling environment, and put together a set of recommended investment approaches that works at multiple levels. There's a set at the global level, a set at the country level, and then thinking about what it takes to actually implement this in practice. So I'm going to start at the top here with the set of recommendations at the global level. And again, these are things that are meant to strengthen the readiness for implementation, regardless of a particular country. They're things that are going to strengthen the global digital health community, and again, be resources that can be leveraged across different contexts. So one of the first most important things here is looking at securing consistent funding for core product development to improve the shelf readiness of existing products. This is addressing some of the technical debt issues that Pierre mentioned in his presentation, enhancing security of products, enabling better testing at scale, and strengthening interoperability of these products through the use of health messaging standards like FHIR. These kinds of investments might even include investing into the ecosystem of tools and libraries that will support the use of FHIR. This kind of consistent investment, won't necessarily eliminate the need for country configuration, but again, the idea here is that strengthening a suite of products in these ways will make them easier to adopt and kind of best position countries to be able to take them up in their own contexts. The second set of recommendations that we talk about in the report and here are filling some of the market gaps. So specifically, this was around kind of context-appropriate consent tools and protocols, things that will support the operationalization of health data governance, given the many use cases in which health data is flowing across systems and through different users. This was, again, a gap area in the landscape where a lot of these tools aren't yet in practice. I think there's also still a lot of discussion and discourse around what this really should look like in different contexts, and how do you do patient opt-in? How do you think about the right models in different contexts for making sure that you are putting into practice the health data governance principles that are starting to be adopted, but not yet implemented in practice across many of the contexts that we see. So those are the top two. The bottom two strategies in the global set kind of address some of the more forward-looking use cases. So we have a strategy here around strengthening and enhancing the market of supporting DPGs and building blocks, right? This is getting at addressing kind of the relatively fewer examples of open data sets, open AI models, open content that can support the development of these applications on top of digital public infrastructure for health. Again, it's not that these kinds of assets are completely absent, but I think not having as many that have been, reviewed for a standard that are trusted, that are easily discoverable, makes it harder for countries to know which ones they should be thinking about adopting, for knowing what are the right use cases where I should apply things like AI models, where are the content that I can draw on in developing applications for my context. So I think these are, again, just building out this market of supporting DPGs to really enable that ecosystem to develop over time. And the last one here specifically looks at the regulation and governance of predictive analytics. Again, these were emerging use cases, but again, I think there's still a lot of room to understand when is it right to adopt these, where do we have the right evidence to know that these kinds of applications are actually helpful and beneficial in a health system, how do we manage some of the intellectual property and data usage rights that go into using them. And so this kind of reinforces, again, the importance of having the right guidance for this, and then, as you'll see in a moment when we switch down to the country, having the governance and regulatory capacity to enforce it. So those four are kind of sitting at the global level of how do we create a stronger ecosystem for everyone to be able to leverage these. If we move down to the number 2 in the bottom left here, you'll see a second set of approaches that really focus on strengthening the country level enabling environment. And these recommendations are largely familiar to a lot of us that have been working in the space over the last decade, but remain really important to be able to put this digital public infrastructure for health approach into practice. We've called out a number of approaches to help strengthen leadership and governance at the country level. And you'll notice kind of the gray bar here is really kind of stage gating, the completion of having a digital health strategy, of having a health enterprise architecture and a costed plan, so that there are those key governance assets in place to support the implementation of a shared infrastructure across the sector. also, concurrent with this in strengthening the environment is investing in that technical capacity, as Pierre noted, challenges around workforce and having a skilled workforce that can work with health messaging standards, people that are comfortable with fire and other health standards are really going to be needed, because there always is that need for local configuration, and having that technical capacity is going to be important to being able to put this into practice and maintain it over time. And then the last row here around regulatory capacity strengthening. Again, just given the importance of the governance piece and the emerging governance pieces around predictive analytics, addressing some of the challenges Pierre mentioned about working with private sector products and thinking about different regulatory approaches to bring those into a public system. There's still a lot of work to be done around strengthening regulatory capacity as well. And then these are both building towards what we see as the third major approach in blue in the center and the bottom, which is coordinating investments to actually take this approach within a specific country context and implement multiple of these DPI-H components. Again, this is really where we're trying to take those assets that have been strengthened at the global level, put them into a country context that has the leadership, governance, technical, and regulatory capacity to be able to implement, and supporting it with what are generally larger investments over a long period of time to get not just one aspect of it, but to really put into place what might look like a functional, secure, health information exchange, right? To have all of those core components in place to be able to start supporting the kinds of applications that we set out to in the user journeys and in all of our programming activities. So the global and the country level really working together towards that. One thing I want to highlight, and you'll see in the middle are these kind of exchange arrows here, is just acknowledging that this is still fairly early on, right? Like these implementations are not something, there's not a lot of mature examples in our landscape. And I think as we start to invest and coordinate investments in these kinds of approaches, there's a lot of learning that will come out of that. There may be opportunities for investments in those tools and products to really contribute back to the global ecosystem. So there's a little bit of back and forth there as we learn through country implementations. It may make adjustments to how we think about the tools, how we think about what the right level of readiness at the global level is. And then lastly, I'll just note that we recognize this is a long process, and some of these might be fixed term investments over the next 5 to 10 years. There's also likely ongoing need, especially for some of these capacity type investments, where it's just a little bit of consistent re-upping, making sure that there's a pipeline of people both at leadership levels and in workforce levels to be able to support this over time, because it's not a short process. So that's really how we're seeing these come together. We're happy to dive into more on any of these recommendation approaches or address other questions. We tried to leave a lot of time for Q&A here, so we'll go ahead and open it up, and happy to hear from you. Thanks very much. You can go ahead to the next slide. So we have, we have also Phil Veltsos from PATH, who's been a really fantastic thought partner in this work and has joined us throughout the journey. He didn't present today, but he's here joining us and happy to take questions as well. Laura, I don't know if there were any that came through in the chat that you want to tee up while people are gathering their thoughts.
No questions yet. Yeah, again, feel free to use the raise hand function or just put a question in the chat.
I'll catalyze a little bit of discussion with just sort of an observation of having played in the digital health space for a while, and also now getting up to speed on digital public infrastructure and taking a hard look at the way some of the infrastructure in India has been built out. I think one of the interesting attributes that has defined digital public infrastructure components is an individual component's use by other elements in the system. So having a very clear modular approach to the architecture of a system. And I think that's something that as a community we have failed to execute against in the digital health space. We tend to build tools that are very siloed and operate by themselves. And any of the individual components don't tend to serve data and integrate with other components in the system. And I'm trying to give some thought as to how we might be able to catalyze both investment and implementation in discrete components that create more of an ecosystem of services within the health space, as opposed to the many silos we currently operate in. So we'd be curious to get anyone's thoughts on both that challenge and possible ways forward.
I see Chris's question around digital public infrastructure in other cross-domain use cases like CRVS and health, and I think that's a really great question. So we've done quite a lot of research into CRVS, and obviously the digital identity systems, which are part of the core DPI framework of or integral piece of that. Connecting that into a health system is more complicated. We haven't seen a lot of that going on. So there is some of that happening in India, in a couple of states with Aadhaar, but exchange of health data, especially around cause of death, etc., is not it's not very mature at all. Amy, do you want to add anything into that?
Well, I think just maybe at a conceptual level, this is really where the role of that services gateway component of the model comes in, and recognizing that, for things like CRVS, often that's a different system. You're in Ministries of Interior, it's held in different places, right? And there need to be ways to link and access between that, so that we're not necessarily repeating those investments in each sector, right? There is a lot of robust discussion around, whether you should have one ID or sectoral IDs, or ways to link it and protect it, so that it's not necessarily a target by having one big database with everyone's health information. But I think, as Pierre said, we're not seeing a lot of that in practice. I think the value is somewhat there, and it's still kind of a how do you implement this in practice by making sure that you can have that exchange of data, not just within the domain, but connecting to other ones and other sectors through something like that cross-sectoral service gateway part of the model. Phil, I don't know if you're on, if you had other comments on that, but you're welcome to chime in as well.
Thank you. Yeah, this is such. Sorry, were you talking to me?
I realized that was a very good cue for you. I actually meant Phil Veltsos on our team, but I'm happy to hear. So no worries. You're welcome.
Sorry. Yes, thanks a lot, Amy and Pierre. I do think that this may be a little bit tangential to the focus of your presentation, but is nevertheless pretty important to flag, at least as a parking lot issue, this whole question of interoperability or connection to the CRVS system. It strikes me that it strikes me that it's pretty central indeed to the use cases, several of them that were mentioned in the context of what a health in DPI for health would need to do, particularly when it does come to mortality. As we know, in many LMICs, even if there's an optimally performing HMIS that captures individual mortality and passes on the fact of death and even the cause to other stakeholders in the system, it may only capture 20%, 30% of the total number of deaths occurring in the country. So for the purposes of many of the use cases, I think that the notion of unpacking that foundational layer of ID into its component parts of CRVS and ID management would do the whole community a power of good. My little soapbox about CRVS. Thanks for giving me the airtime.
Thanks, Phil. I'm seeing a bunch of new questions in there. I don't know, Laura, if you wanted us to direct us in one way, or I can just start at the top.
Yeah, lots of good questions coming in. Amy Finnegan from IntraHealth asks, what's next for strengthening the core software projects at the global level so that solid, secure, core open source softwares can proliferate?
Phil Veltsos, it strikes me maybe this is one that you would like to take.
Yeah, thanks, Amy. And again, thanks for that great question to the other Amy from IntraHealth. So I think the reality for the core software projects at the global level is the fact that they have to be mindful of which part of the layer they actually operate in and how they need to integrate across the digital public health infrastructure, so the DPI for health, as well as any components that may be on the outskirts of all of these different layers. There's definitely, I think, an interesting, I would say, shift in the DPG world where we need to start looking at really where do you actually add value and in which layer you find yourself in order to be able to maximize and leverage what exists around you. So in terms of like strengthening the core software projects, for example, IntraHealth Iris, I think it is definitely an HR system. Is it only for health? Does it actually apply beyond health? These are things for you to consider. And where does your system actually interact with the IDs for health versus the IDs that may be more common at the digital public infrastructure, the foundational layer that Amy was mentioning? These are all good questions. But I think, again, from a pure global software project perspective, making sure that you really identify where do you operate within that pyramid, if you'd like, and where your future enhancements of your projects need to happen to actually like leverage the building blocks that exist at the foundational level, as well as within the digital public infrastructure for health. Hope that answers your question, Amy. Pierre, Amy, anything else to add?
I think just to quickly add, there's been obviously a lot of funding coming in through the digital square mechanism, but maybe thinking around a body like that can accept and disperse funds for core software development, because that's definitely come up as a gap. The core funding to maintain a software development team that can produce shelf-ready software, that's a problem that is consistent across all of the organizations that we've spoken with. Over.
And I was just saying, go ahead, Laura.
Sorry, Amy. Well, I was just going to move on because I think the next question is related to this, but go ahead and finish your thought.
I was just going to say, one of the things that we didn't dive into deeply in this presentation, but you'll find in the report when it's sent out, is a little bit of information on costing around these as well, right? And I think, there is some investment, as Pierre mentioned, that's coming through, and I think it's really worth a discussion of how much is really needed, right, to invest in these products to work as infrastructure, right, and investing in them in a way that's proportional to that, to make sure that they can serve the roles at scale securely in the variety of contexts that we need. So would encourage folks to take a look at that. And sometimes it's also kind of a magnitude and reliability of that funding that's an important piece of this.
Yeah, so speaking of funding, Joseph asks, what are practical ways of coordinating donor agencies based on your experience? Because for him, host governments and donor agencies are the key in making sure that systems are integrated and well harmonized.
Another very good question. Glad to hear so many good questions. So I think from my perspective, I would say that there's a great concept that's actually floating around now more and more called convergence workshops, whereby ministries of health with Ministry of Finance, Ministry of ICT, Ministry of Education are all brought together, including with donors at the onset of project, to make sure that we're coordinating this space. There's also the element that I think we're presenting as part of the report around the total cost of ownership, making sure that everybody understands both the initial investment, the capital expenditure, as well as the operational expenditure. So I think, as Pierre mentioned earlier, we're seeing a lot of evolution on digital health strategy, enterprise architecture, but also like costed investment roadmap, so that, again, when donors come in, if they have a very specific health program or health vertical that they want to invest into, the government can actually also step in, and through these convergence workshops with other ministries, with the donors and other actors in country, can actually take that, if you want, ownership and driving their own digital health architecture and the implementations of systems. But again, it's going to be a coordinated effort, and this is something that unfortunately would actually require more, I would say, leadership from the countries themselves. And this is where, again, capacity strengthening that Pierre mentioned during some of the slides and the challenges that we've identified is still needing to be addressed. So we need to actually build the next set of leaders that understand their role and that actually have the language and understanding required to push back and also like do some of the coordination from the national level. I don't know, Pierre, Amy, anything to add from your side?
Or perhaps Tim, if you, I don't want to put you on the spot, but might have thoughts as well.
I think part of the coordination is there are a couple components of it. One is at what's happening at the global level and what's happening at the country level. There have been some countries that have done a really great job of focusing coordination efforts at the country level, bringing donors and implementers together in country to figure out how to execute. And then I think there's been growing efforts over the last few years to try to increase the coordination at the global level across global donors, and with mixed success.
So also following up on the sort of funding questions, Alex White asks, who are the primary funders of DPI initiatives for health in LMICs?
Well, I think there's a bunch, and there's folks here, obviously, and when we think about even the folks that we spoke with in this report, there was kind of representation across a lot of the major funders. There are groups within USAID, Gates Foundation, CDC, Global Fund, World Health Organization. I'm sure I'm missing some here, but there's a group within all of the major development funders that focus on health. And I think what we're seeing is increasingly investments in health bring you into investments in digital health, right? We're seeing the digitization happen where it's not something that you can necessarily avoid. So I think there's just part of the complication here is that there are so many different funders, right, that are working under different programs, that it contributes to that fragmented state that we're in, that Pierre mentioned, and kind of the importance of taking a more coordinated approach for the shared investment in common infrastructure. Phil, you look like you were going to add to that. No, okay.
So I think we have time for a few more questions. Ernest Bo asks, he's interested to hear guidance about the best approach for technical capacity strengthening in Africa.
Here you're nodding. Do you want to take the first cut?
Yeah, I mean it's a difficult one, you know, trying to ensure that there's a pipeline of skilled technical folks in country is a huge challenge. Especially when there's competition from the private sector, and not only private health sector, but also other sectors, banking, insurance, etc., for those technical skills. But you know, it can go back. You know, in a long term, if you're looking long term, you know, in putting in curriculums at universities and colleges to increase the general level of skill in the country. So that's one approach. The other is having a lot of technical training in the short term. So just training as many people as possible, bearing in mind that there will be a lot of attrition. You know, people that are trained in digital health, you know, will migrate into other sectors. Often sectors that can pay better than than a Ministry of Health can. So that's another thing to look at, is the salary packages that are available in the public sector.
I would also just highlight other approaches too. There's been interest in more public-private partnerships, thinking about how to leverage skill again, if those trained human resources are going into public sector positions, ways to partner and bring that back into public sector. There's also a lot of movement, for different pieces in thinking about vocational training opportunities and different online courses, and just leveraging the wide variety of formats and venues for training, because there's a lot of talent that may not make their way to four-year universities or wherever, right? There are ways to kind of get at that through different pathways. We've got time. Last one, yeah.
I was going to say one final question from Nathan. He asks, what is the strategy for DPI for Health and cross-sectoral collaboration? He mentioned specifically that domains like health and climate are interdependent and rely on information from other sources, such as the Ministry of Statistics. So interoperability really should be addressed beyond health to best bring that needed information into health.
Yeah. Well, go ahead, Tim.
I'll just find that this is absolutely an area that CoDevelop is interested in and pursuing and trying to promote. We've had a couple of conversations specifically around DPI plus climate. In those conversations, people have been quick to acknowledge the overlap with health. There's clearly also lots of use cases that are payments related, whether or not those are payments to health workers for their salaries or incentive payments, or mapping common registries so that you have supply chain systems that are targeting or serving specific locations, and those same locations are being pulled together on government-wide planning efforts. So we see lots of potential for digital public infrastructure broadly, and lots of overlap with various health initiatives, and that's part of the awareness that we at CoDevelop are trying to build with developing countries as they are thinking about their DPI journey. I'd also add that there are other organizations in addition to CoDevelop that are working on this agenda. World Bank has been a strong player with their ID for D and GDP payments efforts. UNDP has recently joined in and thinking about the safety and inclusion side. There have been some other funders. So the DPI agenda seems to be gaining quite a bit of momentum, and we're hoping that it is something that will encourage cross-domain investment.
Awesome. Well, I think that brings us to the end of our time. Thank you so much for all the great questions and engagement. Seems like we'll definitely be following up via email to share the slides, recording, and report, which I also just put in the chat. And hopefully some other great collaborations are coming out of things shared in the chat as well. Yeah, thanks again.
Thank you, Laura. Thanks to Path. Thank you, Tim. This has been a really great, engaging project, and we're happy to have had the opportunity to share it.
Thanks, everyone. Great presentation.
Thank you.
Thanks, everyone.
Bye, everyone.